Good afternoon, everyone. I am Dr. Krishna from the Medical Affairs team at Dr. Reddy's. I take this opportunity to welcome you all to the webinar session today on functional abdominal pain disorders. We have an international speaker to deliberate the session today, and which is also moderated by a pediatric gastroenterologist. It's my privilege to welcome Dr. Baswati Acharya to this webinar on functional abdominal pain disorders. Dr. Baswati Acharya is a consultant pediatric gastroenterologist from Kolkata, and she completed her education, graduation and post-graduation in India, and went on to do MRCPCH from the UK, and she's completed DNB as well, apart from this degree. Dr. Baswati previously used to work as a consultant pediatric gastroenterologist in the UK at Alderhay Children's Hospital and Royal Hospital for Sick Children in Glasgow. And in India, she is currently the consultant and lead of Department of Pediatric Gastroenterology at AMRI Hospital in Kolkata. And Dr. Baswati is also completed fellowship in clinical fellow in pediatric hepatology and liver transplantation, and she has many noted publications to her name and is a well-known speaker in national and international forums. I hand over the session to Dr. Baswati, ma'am, to take it forward.
Hi, thank you, Krishna. So it's indeed a great pleasure today for me to be a moderator in this session where we have an eminent guest speaker from Italy. It's Dr. Romano Claudio. I have given the responsibility to introduce Dr. Romano Claudio. He is the Associate Professor of Pediatrics in University of Messina, Italy, and he is also the Director of Gastroenterology as well as Cystic Fibrosis Department in G. Martino University Hospital. That is, I guess it's a part of University of Messina. And he is also the visiting professor in Harvard Medical School, and that's a very prestigious position for him. Not only that, he is a very sincere researcher and eminent speaker. So today he is going to speak on functional abdominal pain, especially on the role of Lactobacillus reuteri in functional abdominal pain of children. Functional GI disorders are on a rise all over the world. So we don't have a particular statistics from India, but actually if we quote some statistics from clinical gastroenterology and hepatology, it varies from 12% to 29% of the gastroenterology attendees in the pediatric gastroenterology division. So it is actually variable, but we can see that it's rising. So it's very pertinent today to discuss about this. And without further delay, I would like to invite Dr. Romano Claudio to talk on your research as well as on the functional abdominal pain of children. Over to you, Dr. Romano.
Hey, thank you very much for the invitation. For me, it's a very pleasure to stay here with you and to speak about the functional abdominal pain in children. That is a very important topic now, and in India, but also in all the Europe, and the new talk about the non-pharmacological therapies in this condition. So I want to start my presentation. I hope that now you can see my slides. Okay, thank you very much. So I speak about the role of Lactobacillus reuteri in functional abdominal pain disorders in children. So I hope to. Okay, these are my disclosures. So we start to speak about the definition of a functional gastrointestinal disease, because the definition is changed in the last years. So we can speak that functional gastrointestinal disorders are symptoms arising in the mid or lower gastrointestinal tract that are not attributable to anatomic or biochemical defects. The symptoms include abdominal pain, early satiety, nausea, bloating, distension, and disorders of the defecation. So the epidemiology of this condition is different in worldwide. So we can say that we have the prevalence range from 1 to 6% to 41% in the pediatric population. And there is a difference from, I don't know, South of America, Asia, and Europe. In these slides, you can see that there is most prevalence in the south of America, in the north of America, in the north of Europe. And we can see that also in all worldwide, the prevalence is very important. In the 1990, a group of experts that we know, Rome group, defined the definition of the functional abdominal disorders in adults, also in children. So this is the last classification, and you can see a lot of conditions: esophageal disorders, gastroduodenal disorders, a lot of upper symptoms, I don't know, nausea, aerophagia, epigastric pain syndrome. And the most prevalent disorders are the bowel disorders: irritable bowel syndrome, functional bloating, functional constipation, functional diarrhea, abdominal pain syndrome. And these are the very important conditions, and we speak about these dysfunctional disorders. There are a difference in diagnosis between ROM3 and ROM4 classification. ROM4, it's possible a positive diagnosis of functional gastrointestinal disorders. And in ROM3, the diagnosis was considered as an exclusion diagnosis. After you are sure that there are not by also the possibility to do instrumental exams to define this condition as functional gastrointestinal disorders. So here you can see the last classification, but also the last definition. I don't know, irritable bowel syndrome is considered abdominal discomfort or pain that can be associated with improvement with defecation. This is very important, and this is the differentiation by abdominal pain or functional abdominal pain. Onset associated with change in frequency of stool, onset associated with a change in form of stool, and another important diagnostic criteria is that no evidence of an inflammatory, anatomic, metabolic, or neoplastic process that explain the subject symptoms. So the symptoms are present at least 2 months before the diagnosis. Another condition that is different to irritable bowel syndrome is functional abdominal pain. Functional abdominal pain is considered episodic or continuous abdominal pain. There are insufficient criteria for other definition of functional gastrointestinal disorders, and also in this condition there are no evidence of an inflammatory, anatomic, metabolic, or neoplastic process that can explain the symptoms. Also in this condition, the symptoms are present for at least 2 months. So in the Rome 4 criteria, we can consider also this condition. There is a syndrome of functional abdominal pain. Syndrome is considered a condition where we are gastrointestinal symptom, but also somatic symptoms such as headaches, limb pain, difficulty to sleeping. In this condition, we we define this association as syndrome of functional abdominal pain syndromes. So it is very important to define that we are the pathophysiology in brain, in the gut. In the brain-gut axis, we consider the most important mechanism. We know that the interaction between brain and the gut is bidirectional. Brain receives a stream of interoceptive input from the gastrointestinal tract, integrate the information with other interoceptive information from the body and with contextual information from the environment. So in FAP syndromes, we are a conscious perception of interoceptive information from the gastrointestinal tract can occur in the form of constant or recurrent discomfort of pain or pain, and this is different the level from between the patients. So we have a visceral stimulus that in the gut. We active a network processing afferent homeostatic after the perception of the stimulus. And in the patients, we are different emotions with different perception, different condition of the pain. So we can define this is a very important process to understand the pathophysiology of functional abdominal pain in children, but also in adults. And in the physiopathology, we consider also the very important factors, predisposing factors for the, IBS or functional abdominal pain. The sex is very important. We know that in children, the family is more frequent in the family sex about this condition. Physiological factors, age. We know the range of age in pediatric population is from 8 to 12 years. The gastrointestinal infection are very frequent to start this condition after the infection, gastrointestinal infection, as a post-infection disease. The diet and the early event life in neonatal age can consider as very important to determine functional abdominal pain in pediatric age. You consider that the colic is very important, and this condition is predisposing to functional abdominal pain in children 8-10 years. So we know that now there are new pathophysiological models, and new models is very important. Is a top-down model, a bottom-up model. What is the top-down model? Top-down model is a model in which we have the alteration in the central nervous system started by various stressors directed at the central nervous system about exteroceptive stimulus, such as adverse life events, anxiety, depression. This condition can cause alteration of the activity of the enteric nervous system through the autonomic nervous system and the hypothalamo-pituitary adrenal axis, causing physiological change in the gut, including visceral hypersensitivity, alteration in motility, in permeability, in secretion, in immune reaction, and in microbiome. And this is the very important mechanism. In the bottom-up model, we have various stressors directed in the gut that can include the central nervous system and alter the cortical response at the visual stimulus with the IBS symptoms. So we can consider, intestinal infection, mucosal inflammation, gut distension, immune-mediated reaction, food allergy, and dysbiosis. The alteration in microbiome is considered very important condition in these symptoms. Increased intestinal permeability, abnormal response to the enteric nervous system to gut stimuli. But we know that in the same patients, both the model can be present. The microbiome we have seen is the very important mechanism to modulate the visual pain in functional gastrointestinal disorders. So in the dysbiosis, one of the most important condition is the alteration of the regulation of serotonin. Serotonin regulation can determine gastrointestinal symptoms, can determine the alteration of the perception of the visual stimulus at the brain, to the brain. So the dysbiosis in the microbiome has an important role in this condition. So after we have seen the pathophysiology of functional gastrointestinal disorders, we have to know what is the treatment, the modern treatment. The modern treatment is not pharmacological treatment in functional gastrointestinal disorders, but the first treatment is counseling and parental education. Cognitive behavioral approach is very important in these patients and in these families. Medication, diet, and some therapies as probiotic, use of probiotic. So I wanted to see you a simulation of the approach to the patients, to the family with functional gastrointestinal disorder. I don't know, the parents ask, doctor, what is causing my child's pain? The doctor reply, I am not sure yet, but we'll try and help your child and you as we navigate through this process. It's possible we will wrong before we find out what is causing it. And it may be that the symptom is the disease. The symptom is the disease, like it is in the stomach. So this is a simulation of the approach that is very important for the doctor, for the pediatric gastroenterologist that see family with functional gastrointestinal disorders. So we have seen the role of the human gut microbiota. The intestine and gut microbiota is considered as a gut keeper of the homeostasis and in prevention of dysfunction of this condition. So I don't know, when we have dysfunction of microbiota of this gatekeeper, we have the predisposing factor to obesity, to metabolic syndrome, to diabetes, to infection, also to inflammatory bowel disease. We know we have demonstrated it, but also for the functional gastrointestinal disorders, the mechanism is the same. We know that we have a lot of strains in our microbiota. We have Firmicutes, we have Actinobacteria, we have Bacteroidetes, we have Proteobacteria. So the gut microbiota is very important to several functional contributions: synthesis of vitamins and harvest of otherwise inaccessible nutrients, metabolism of xenobiotics and other metabotypes, renewal of the gut epithelial cells, development and activity of the immune system. So we know that in IBS, but in functional abdominal pain, functional gastrointestinal disorders, the alteration in colonic microbiota, in intestinal microbiota, diversity, stability, and the metabolic activity of the gut microbiota are altered in most patients with irritable bowel syndrome. There is a reduction in bacterial diversity. There is increased temporal instability of the gut microbiota. There is a relative abundance of Firmicutes in strain as Ruminococcoce and Clostridium, and the reduction of Bacteroidetes. So IBS is also associated with increase of chain fatty acid production. It is a very important factor that can contribute to change in visceral pain response and in visceral motility. So in pediatric patients, it was demonstrated that there are in IBS patients more presence of Haemophilus parainfluenza Proteobacteria and the less representation of Bifidobacteria and Lactobacillus. So we can consider probiotics very important in the management of pediatric functional abdominal pain, but not in treatment, but in the management. This difference is very important because we have seen that the cognitive approach is the most important approach in this condition. We have studied a lot of strains: Lactobacillus GG, Lactobacillus reuteri, Bifidobacterium lactis, and VSL3 can be considered the most studied strain in the treatment of functional abdominal pain. So for Lactobacillus GG, we have different meta-analysis, but you can see in this meta-analysis that the most important results are perhaps in functional dyspepsia and not in irritable bowel syndrome and functional abdominal pain. And about Bifidobacterium lactis, for example, we have this study. This study was conducted in children with constipation. The Activia supplementation with Bifidobacterium lactis increase stool frequency. We can see in the third week, but this stool frequency increase not was significant in this study. And we have a lot of study about the use of Lactobacillus reuteri. We have also our study about the treatment of functional abdominal pain. And in our study, we have a population of children, 30 children with Lactobacillus reuteri and another placebo without treatment. And we have demonstrated that in this population there is a significant reduction of intensity of the pain and not significant reduction of the frequency of the pain. But the reduction of the intensity was very significant in a group with treatment with Lactobacillus reuteri. So there is another study about the use of Lactobacillus reuteri. And this is a randomized double-blind controlled trial in children 4 or 6 years with chronic functional abdominal pain. Diagnosis based on ROM3 criteria. And 40 children received the probiotic and 40 the placebo. We can see in this study that the severity and the frequency of abdominal pain in the first month compared to the baseline was significantly less. At the end of the second month, the difference was not significant. So this study, the conclusion was that the severity of pain was reduced in both groups, but in the first month is more significant in group treated with Lactobacillus reuteri. So there is another study about the administration of Lactobacillus reuteri in beneficial and functional abdominal pain in child. So is 100 children, 50 years, with diagnosis on the ROM3 criteria, with functional abdominal pain. The Lactobacillus reuteri group was significantly superior to placebo in reducing the frequency and intensity of the pain. So in this study, in difference of my study, the reduction was significant also in frequency and in intensity of the pain. And the supplementation was for 4 weeks. The conclusion of this study was that Lactobacillus reuteri compared with placebo significantly reduced the frequency and intensity of functional abdominal pain in children. But we have other study. This is a study by Espagan, and you can see in this group in one important hospital children in 2 years, the supplementation, the children was randomized to receive Lactobacillus reuteri or placebo. This was a prospective study, very important. Data were analyzed for 55 children, and the children with intervention, with supplementation with Lactobacillus reuteri had significantly more days without pain than control group. The results of this study was very significant about the possible reduction of the intensity of pain in treated group with Lactobacillus reuteri than in group with placebo. So the last study that I present to you is another study about the Espagan group. This study assessed how effectively the probiotic Lactobacillus reuteri is important in the management of the functional abdominal pain in children. 45 children in 3 university hospitals in Greece, Slovenia, and Poland. You can see that this is a prospective study for 2 years, and the results was that the significance of the supplementation is not very important in Lactobacillus reuteri group than the placebo, but the Lactobacillus group decreased the use of the pain-relieving drugs at 4 weeks, and a number of child, school, and adult work absence was a significant reduction. I can consider these very important results than symptoms or the management the symptoms. So we have presented the results of the study where Lactobacillus reuteri was used in this patient. But the strain of Lactobacillus reuteri are two. The first one that we don't use now because it's the ATCC Lactobacillus reuteri strain. This strain to carry potentially transferable resistance traits for tetracycline and lincomycin, but the new strain is very important because it's a bioequivalence to the first strain, but without the possibility of a plasmid-borne resistance. So very important to use in pediatric population. And it was demonstrated also that Lactobacillus reuteri is very important because the colonization of the ileum of the intestinal mucosa is significant in these animal models after 28 days use of this supplementation. You can see Lactobacillus reuteri in situ, and the presence in situ of in the ileum mucosa that is very important to develop antimicrobial activity, to the regulation of immune response. And another study, it was demonstrated before and after supplementation with Lactobacillus reuteri that there is an important modification of the immune mucosal response. There is a more representative presence of the CD4 cell T helper, the recruitation of the cells in the mucosa, in the cell of the mucosa, and with more production also interleukin-10 that is very important to the regulation of the inflammation. So in conclusion, we can see several key points. Studies have demonstrated that the change in the gut microbiota resulting in altered host function is relevant in functional abdominal gastrointestinal disorders and in mechanism, pathophysiology mechanism as gut motility, visual pain responses, intestinal permeability, and brain function and behavior. So the gut microbiota composition is very important pathophysiology mechanism and is altered in patients with functional gastrointestinal disorders and IBS most commonly. So interest exists in the ability to modification of the microbiome, intestinal microbiome, and this is very important to influence the gut and the brain function and in the perception of the pain. So dysbiosis in this condition is characterized by a loss of microbial diversity, and there are many factors. In these many factors, we can include diet, stress, infection, antibiotic use, immune activation, and low-grade inflammation. And now we have a lot of studies that consider Lactobacillus reuteri the most important treatment, the most important strain, the most important studied strain in the treatment of functional gastrointestinal disorders, but also to the treatment of infants' colic. And this is the treatment that we can consider therapy microbiota directed. And with the last my slides, with my town in Sicily, I want to thank you for the attention.
Thank you, Dr. Romano, for an excellent deliberation. We had quite a few new other research what we found about lactobacillus reuteri. You highlighted on, and the pathophysiology and the action of lactobacillus reuteri at the same time. So, Krishna, should we go for the discussion of the questions, and or
We can start
anything
the
you want
questions.
to ask first?
We can start the questions, ma'am. Meanwhile, I'll
Okay.
pull in the questions first.
Yeah. So, there's the first question. What is the typical patient profile of functional abdominal pain you encounter in day-to-day practice? Dr. Romano.
I think that you consider the classification of ROM 4, and I think that the typical profile of the children is children with IBS, with irritable bowel syndrome, with alteration of the frequency of the stool with constipation or with diarrhea. This is the most frequent condition in Europe. The second one, you can consider also the functional abdominal pain syndrome, where we have also a lot of symptoms out of the intestinal, gastrointestinal condition. I don't know, head haze, nausea, and specific symptoms. These are the most frequent conditions where I see the long use of the probiotics.
Okay, thank you. Next, we have a question that what are the potential signs and symptoms that needs to be ruled out before leveling these patients as functional disorder, functional GI disorders or functional abdominal pain?
Can you repeat, please, because I don't understand the...
I think the question it did mean that what are the, red flag signs and symptoms, which or the some other signs and symptoms you want to exclude before you level them
Okay.
as functional disorder.
The red flags you...
Yeah, I think that is the question, yeah.
Yeah, red flags, I don't know, are, we know in abdominal pain are fever, weight loss, are the presence of the alteration of the stool, the presence of the vomiting. These are considered the red flags. And now in this condition, we have to do instrumental exams before the diagnosis of functional gastrointestinal disorders.
There's another interesting question, that is investigations required for diagnosing functional abdominal pain? Do we at all investigate, or it will be only a clinical diagnosis?
But yes, this is a very important question, because the ROM4 is real that we have to do a positive diagnosis. But I think that in children with abdominal pain, with 2 months with abdominal pain, important, sometime also in the night, we do the basic exams. I don't know, celiac disease screening, exam of the stool, parasitologic parasitic in the stool. I think that these exams perhaps are useful to do in pediatric population.
So
are you agree about it, or you prefer to?
Yeah, we do. Actually, when they come to the gastroenterologist, actually we sometimes have to exclude the basic things. We always do an ultrasound. We always do exclude celiac or thyroid, especially those who have constipation, and basic stool, especially in our country, to exclude the parasitic infestations and all this. So basic things we always do, and but not sophisticated. That is the rule.
Yes,
if you are really sure about functional, but sometimes they have like mixed little bit of red flag. That time we have to little bit more investigation is needed. Sometimes ultimately we may have to come to a diagnosis of functional abdominal pain, but sometimes it's a little bit more because when they're very anxious.
Can I do a question for you? In India, there is a use of the ultrasonography, abdominal ultrasonography in the management of abdominal pain. I don't know, because in Europe, the pediatrics, the pediatrics of basic pediatric use in all of these people ultrasonography. I think that in children with abdominal pain, ultrasonography is not very useful to
Yeah,
define
mostly it's,
the
see,
presence
most,
of the organic diseases. I
yeah,
don't-
it's not differentiating organic disease, but if it has some findings, then it will help you. But only to that nowadays, like polylithiasis and all these few findings are increasing, but that does not always actually mean that pain the child is coming with is
yeah.
really for that particular cause. If there, even if there is finding, so we have to critically correlate with the finding. But ultrasound sonography is basic finding because sometimes important diagnosis nobody wants to miss. That's why
Okay.
we do a basic ultrasound whole abdomen. Though we know that yield is only 1%. I mean, if it is functional abdominal pain, there is nothing.
Okay.
And there is another question that apart from probiotic, if there is any other current therapeutic modality which Krishna has posted, any current therapeutic other modalities for functional abdominal pain or functional GI disorders, and how long we have to continue the treatment.
About probiotics, I think that the treatment is about 2 3 months, because you can see that the symptoms are less frequently. The pain is the intensity of pain is reduced after I don't know 2 3 weeks of the treatment. But if you want a long, good follow-up of this child without the possibility of the relapse of the disease, so it's very important to do 2 3 months of the supplementation with probiotics.
So if somebody continues this more than 3 months, will it give some extra benefit or it will be the same?
I think that the child with irritable bowel syndrome will be the adult with irritable bowel syndrome in many cases. So it's very important to prevent this condition or this possibility. So we don't have the study that was demonstrated that the longer follow-up, the longer treatment with the probiotics, with diet, with the cognitive behavioral approach can prevent the possibility that the children is the adult with irritable bowel syndrome. But I think that it's possible that good treatment in pediatric age can prevent the possibility that this child is an adult with functional gastrointestinal disorder.
There is another question from Dr. Vishwanathan. He is a pediatric gastroenterologist. He is saying that did you use capsule or sachet preparations when you did the research you
It's a,
studied?
in my study we use the capsule of the Lactobacillus reuteri, but it's the same, I think. Liquid or capsule is the same about in the treatment. So,
Okay.
can you explain me in India? You have the tablets. Do you have Lactobacillus reuteri? Do you have also Lactobacillus GG? Do you have WSL3? The probiotics that are used in functional gastrointestinal disorders, just in pediatric population, but also in adults.
So in adults, what I have seen, because I have worked with adult people, they use more VSL3. You know the combination because now it's like
Yeah, yeah.
Visbiome, the other product. And in children, here we use quite a lot of lactobacillus GG nowadays because it is available for last 5 years. Before that, it was not available, but prior to that, we had Saccharomyces boulardii and uh, what are the Bacillus chlorzi. But
Oh,
those were not actually used in functional GI disorders. Those were used mostly in diarrheal disorders or sometimes some
okay,
few IBAs with diarrhea, predominant IBAs, but not like all functional GI disorders because they didn't give any particular benefit in the functional abdominal pain group. But Lactobacillus reuteri is available for last 2 years, rather 2.5 years. And initially it was in drop form and now it is in sachet. So now it is in tablet. So we have these two forms available. So we are using mostly these two forms of Richery nowadays in functional abdominal pain. But there are few pediatricians as well as gastroenterologists. They are also using GG, especially when there is constipation associated functional GI disorders. Or, but we are. I don't know other practices, but mostly I am using Richery at the moment for this functional GI group because it is giving better response. I'm
and
just lost
yes.
the questions. Yeah, you tell me.
Yes, yeah, I want to tell you about the use of the pharmacological therapy in functional gastrointestinal disorders. This is a very important problem because in Europe, perhaps in functional dyspepsia, there are a lot of children that use inhibitor of pump proton drugs. There are the easy prescription of this pharmacological therapy that we don't consider this therapy very useful in children.
Proton pump inhibitors, especially upper when it is esophageal gastric symptoms. Yes, actually we have also, I mean, presented this study in the functional abdominal symptom group where we are not finding anything in the endoscopy, who have severe pain, and in those cases we have looked for small intestinal bacterial overgrowth, and it was a significant portion who showed small intestinal bacterial overgrowth, even who have only epigastric symptom, epigastric fullness, heartburn, and all these esophageal gastric symptoms. So that's why actually PPI we are not using routine. If you are really thinking that it's mostly functional GI, so we are not using PPE, but it's randomly used everywhere. I mean, often they come with already used PPI for like 1 to 2 months at least.
I have seen a lot of question in one question that I have seen now in chat.
Yeah, you can see that.
In chat, yes, it was about the use of a FODMAP diet
Yeah.
in children. I think that in adults there are data about the use of the FODMAP diet. In children, we don't have the studies that was demonstrated the useful of this kind of diet. I think that the diet in children is stressful for the family,
Exactly.
for the children. I don't know if this approach can be considered in pediatric population. We don't use a lot of milk. We don't consider use of fruits. But the diet, the very indication of the indication for the diet is not useful in functional abdominal pain in children.
And there's another question, however, what I can see is the psychiatric options. Are you routinely referring to psychiatrist or cognitive behavioral therapy, or you try to do some therapy first and then psychiatric counseling?
I consider the cognitive behavioral therapy the most important therapy because we that are pediatric gastroenterologists and we see a lot of these kind of patients. We have to have a different approach When we speak that the children, we do the diagnosis functional abdominal pain, it's not inflammatory bowel disease, not another organic disease, but it's important to maintain the follow-up of these patients. No, not just one visit, but 2, 3 visits to evaluate the follow-up. I don't know. We use also the diary of the symptoms. The child write every day the hour of the pain, the grade of the pain, the localization of the pain. All it's considered important for the for the doctor. So the follow-up is very important in this population, and the pediatric gastroenterologist not the activity of the pediatric gastroenterologist is not limited to use probiotics, but use probiotics and together cognitive behavioral approach.
Yeah. So there is another question. How is the pain from constipation is different from functional abdominal pain in children?
I don't know. Well, I like to have also your rep about this interesting question. We have the macrogol now. I think also in India use the macrogol for the treatment of constipation. The macrogol is a very good pharmacological therapy, but we have the macrogol, and we have in our pediatric emergency unit arrive in 1 year, I don't know, 100, 200 children with abdominal pain secondary to constipation. This constipation was not treated and is not good because 10 years ago we don't have the macrogol, we have the lactulose, with the difficulty to have the compliance of this kind of treatment. We have the macrogol, but now we have a lot of patients that arrive in emergency unit with constipation, with fecal impactum, with important complication of the constipation, and with abdominal pain. So it's very important to prevent this condition.
Yeah, I mean, to my opinion, it's really this is a very difficult question to answer. But the problem is that there is an overlap. If it is a functional constipation and there is some pain, it can have overlap. They might have, when the constipation is relieved, they might have little bit reduction of pain, but might be it can continue again in a low intensity. So I don't know. I mean, it's sometimes clinically you have to really assess individual patients and you got to take decision individually. So there is another question. Did you find recurrence of FAP after stopping lactobacillus reuteri?
In our study, I speak about our study, but also about my experience. After 1 year, half 1 year, we can see that a group of children can have the relapse of the pain, of the symptoms. So we can use for another time the supplementation with the probiotics, but 2 months after 2 months we have a good response to the therapy.
Okay, yeah, thank you. And there is another question that they're saying, even if when you are giving probiotic, do you need symptomatic relief of the pain? Do you need to continue symptomatic treatment?
What do you consider symptomatic treatment?
Because here they have given, are you using antispasmodics? I mean, the question they have given.
This is a very important question, Because,
Or are you using antidepressant as well? That is
no,
also in the question.
antispasmodic, antispasmodic drugs, there are a lot of drugs. I don't know if it's very important to use the pharmacological therapy in this kind of population. Because if you use pharmacological treatment, you confirm that it is organic disease. This is, there is alteration, organic alteration. We have to arrive don't to use pharmacological therapy. We can use one time, two times in 1 month, but every day to use antispasmodic therapy in this kind of children is not considered very useful. In cognitive behavioral approach, you have not considered the use of antispasmodic drugs. And you can use placebo, for example. We have seen that in many studies, if you use a placebo in this population, you have good results about the symptoms.
Krishna, are we left with any other question? I think we have discussed most, because I have few, 2-3 questions, like what you have already mentioned, that how many days you have done the research and how many days you have to continue the treatment with lactobacillus reuteri if you want. There are so many times this question was repeated. And FODMAP we have already discussed, and how is literally beneficial. And there is a question that how does literally reduces the pain? But you have discussed in your in the presentation, but you can tell it again.
You can repeat the
mechanism. The mechanism how lactobacillus reuteri can reduce the pain.
But reduce the pain because there is a modification of the immune response to the intestinal, to the gut, in the gut. The modification of the composition of the gut microbiota can consider that reduce the hypersensibility of the pain or in this kind of children. So we have more lactobacillus, more bifidobacterium, less firmicutes, and these modifications are very important to modify the gut-brain axis and the transmission of the visual stimulus.
Yeah. So I think that's, we have most of the questions we have answered. I just asked Krishna that whether, Krishna, do we have any more questions coming up? Because I can't see anything which is not discussed here in the
We have one more question.
There is more question about the constipation use in the constipation use of lactobacillus reuteri. The studies that we have use of the lactobacillus reuteri for 4 weeks. I think that is not enough 4 weeks. Also in constipation, that in other conditions, other functional gastrointestinal disorders, 1-2 months is the good treatment for the resolution of the problem.
I think we've done with the questions, Dr. Romano and Dr. Basuti. We've done with the questions. Would you like to give a take-home message on the talk for the audience who are listening to you right now about the summary of functional abdominal pain disorders, and what would you recommend as a take-home message?
I don't.
Could you give it the question? We have done with the questions. I think there is one more question which has come.
Yeah, just came now. Yes. Significance of mesenteric lymph nodes and its size in abdominal pain, especially functional abdominal pain. Is any relation or significance?
I think that there is a relation because in functional abdominal pain, but in all functional gastrointestinal disorders, there is a low grade of inflammation mucosa. So the intestinal chial cells, I don't know, the chial cells are very important to the transmission of the visceral pain, of the stimulus of visceral pain. So the low-grade inflammation that you can see perhaps after a gastroenteritis infection, gastroenteritis, we have a lot of children with post-infection gastroenteritis disease. There is inflammation, but in this post-infection disease, we see that the symptoms are present for 2-3 months, and then there is a spontaneous resolution of the symptoms.
And lastly, I have one question. How many cases of small intestinal bacterial overgrowth you see in your functional GI disorder group of children?
How many?
How many percentage of patients will have time to time bacterial overgrowth, small intestinal bacterial overgrowth, SIBO, in your population? I mean, in the group
SIBO is another important condition. In Europe now, but I think also in America, there is a use in the pediatric population to stop introduction of the gluten. There is a lot of pediatrics that start the gluten-free diet in SIBO, because there are a lot of adults that stay well when they don't eat gluten ferment in the diet, and in pediatric population is not recommended to use gluten-free diet in functional gastrointestinal disorders. So the SIBO is present, but is less frequent that IBS or that functional abdominal pain syndrome.
Okay, but we have a certain, I mean, very few percentage, like 1% celiac disease patients who are on really well compliant gluten-free diet, but still their growth was not adequate. So we then again we did tested for SIBO, and then became when they showed positivity, we treated them with rifaximin, and then they actually showed improvement. So it's not only gluten which was responsible, but they were on gluten-free diet for like at least 1 year, and their anti-DDG IgA was less, and their biopsy was actually normal after 1 year. After 1 year, but still they were not growing adequately. But their growth actually improved when we treated the SIBO. So we proved it by hydrogen blood test, and then we treated it. So how would you explain that gluten-free diet with SIBO? And
I think that the gluten is not is a very important antigen that alter the motility, the sensitivity in intestinal in every condition. So now the gluten products is very rich, very high gluten percent present in the bread, and so the people, the white people, don't consider the gluten the antigen that you can have a good digestion. So many people prefer to eat maize, to eat rice, and don't eat gluten, or reduce the gluten in dairy diet. In Italy, in Europe, is very frequent this condition.
so are you talking about non-celiac gluten sensitivity or gluten intolerance?
Yes, gluten. I think that I don't know.
I know that's another discussion.
What is the difference for intolerance for sensitivity? But I don't know. There are many people that are not celiac but stay well if don't eat gluten.
Yeah, in the functional GI group or in
Yes,
general.
yes.
Yeah. Okay. So Krishna, I think this is time to wind up. Or yeah.
Sure. So, on behalf of the DIP. I thank the DIP for providing us this platform, and on behalf of Dr. Reddy's as well, I'd like to thank the speaker for today, Dr. Claudio Romano, who has given a lecture on functional abdominal pain disorders, and Dr. Baswati Acharya, who has moderated this session to take questions from audience and give a Indian perspective as well. I thank both of you for taking out time today, and I thank the attendees, and we hope that it turned out to be a beneficial session for you all this afternoon. Thank you very much. We can conclude the session.
Thank you also for me, and then I wanted to start a collaboration also with you about the possibility to do a trial, a clinical trial about functional abdominal pain in children in India, and I think that this is.
So we will be happy to do that.
Okay, I don't have your mail.
We have our society. We have our ISPEGAN society, so we can collaborate with through ISPEGAN, and we can with your mail. I will write to you, and then you can get our mail, and then
I wait your mail so we can start the collaboration.
Yes,
thank you very much.
Yes, please. Thank you so much.
Okay.
Thank you so much. It was really great to hear you.
Okay, thank you.
Thank you.
Thank you, madam. Thank you, Dr. Krishna. Thank you, Dr. Romano.
Thank you.
Thank you so much.
Bye-bye. Bye.
Bye.
Bye, madam.